Hi everybody, my name is Dr. Ermias Grafi. I'm a board certified internist, currently working as a hospitalist in Pennsylvania, the United States. As a hospitalist who covers the medical floors in the ICU, I get a lot of calls from nurses. And I would have to say one of the most common reasons why I get a call from a nurse is because of an elevated blood pressure in a patient. Oftentimes, I get a call from a nurse saying that the patient's blood pressure is 170 over 90, but they don't have any PRN blood pressure medications ordered, and they will urge me to order something to bring down the blood pressure. But should I order an IV blood pressure medication for a patient with a blood pressure of 170 over 90 who is asymptomatic and has no evidence of any acute end organ damage? This is why I decided to do this video today, looking at the evidence at who should be treated and who shouldn't be treated while having elevated blood pressure in the hospital. Elevated blood pressure in the hospital is a very common finding, and oftentimes it's a physiologic response to the stress that the patient is going through, including pain, anxiety, or it could also be because the patient has hypertension that they take medications for at home, and those medications have not been restarted when they were admitted. So not every elevation in blood pressure in the hospital is equivalent to hypertensive emergency. There is this new recommendation from American Heart Association as to who should be treated emergently for elevated blood pressure in the hospital. And the first thing that they came up with is change the terminology that we use. We're all aware of our previous terminologies that we use, including hypertensive urgency, malignant hypertension, hypertensive crisis. All these terminologies have some sort of urgency in the naming that would actually expect the physician to do something right away because something ominous will happen if they don't. But oftentimes that's not right. So now we have a new terminology which focuses on whether the patients have end organ damage or not. So, by definition, any blood pressure above 130 over 80 is hypertension. We all know that. If it is above 180 over 110, then that is markedly elevated hypertension. Previously, this one was called, referred to as hypertensive crisis, but that naming is now obsolete. So we just use the word markedly elevated inpatient blood pressure. And if there is an evidence of a new or worsening end organ damage, then this is called hypertensive emergency, because this elevated blood pressure can actually worsen this end organ damage. And the end organ damage that we're talking about, I think everybody knows, are acute coronary syndrome, acute aortic dissection, stroke, or acute vision abnormalities. In these scenarios, the patient should be treated promptly, and we have different targets and different recommendations as to which type of short-acting blood pressure medications need to be used in these scenarios. But what if the patient has no end organ damage? Then this is asymptomatic, markedly elevated inpatient blood pressure. And not all patients with this should be treated. Of course, some patients with persistent elevation of blood pressure can be considered for treatment, but treating a patient with no end organ damage with an IV medication just to bring down the number is probably associated with harm than benefit for the patient. So what does the evidence show? The evidence shows that aggressive blood pressure lowering in patients with no end organ damage is associated with acute kidney injury, ischemia, hypotension, elevation of troponin levels, and longer hospital stays. This JAMA study, which was published in 2023, clearly shows that aggressive treatment of inpatient asymptomatic elevation of blood pressure is associated with worse outcomes, including death, ICU transfers, most importantly, acute kidney injury, and hypotension. So by treating these patients with IV medications, you're actually harming them rather than benefiting the patients. So you can pause the video and look at this slide here. This is from the American Heart Association recommendations, right? So any patient with blood pressure above 180 over 110 and evidence of acute or worsening target organ damage, then they need to be treated according to the guidelines for each acute organ damage. But for those patients who does not have any evidence of acute organ damage or worsening of an acute target organ damage, then you have to look at what is going on with the patient. If the patient is a non-hypertensive patient and they take oral medications at home, it will be prudent to restart their home medications and adjust the home medications. If the patient is not a non-hypertensive patient, then you should be looking at other reasons why the patient could be having high blood pressure, including pain, anxiety, and other physiologic stressors. Of course, if the patient is persistently hypertensive after staying like 7 days in the hospital, then you might be looking at a patient who has an undiagnosed hypertension, and these patients might need to be treated on some sort of treatment based on the chronic hypertension management guidelines. But again, none of these patients would require an acute intervention to bring down the blood pressure. At that point, you're just treating only the number and probably the anxiety of the nurse who's taking care of the patient who is bothered by that blood pressure seen on the monitor. So the bottom line here is asymptomatic elevation in blood pressure is common in inpatients, and acute treatment of elevated blood pressure with no in-organ damage in the hospital with IV medications or short-acting medications do more harm than good. So let's treat the patients and not numbers. Thank you for watching the video. I hope this is useful to your practice. If you like the contents of this channel, please subscribe and hit the like button. If you have any comments or questions, please write them down in the comment section and I will get back to you. Until my next video, ciao.